So here are the objectives. Today we're going to define shared decision making and why it's important in modern physical therapy practice. We're going to understand when shared decision making is useful with a provided framework. Also, we're going to provide strategies that clinicians can utilize to foster shared decision making. So this slide is a picture of the three pillars of evidence-based medicine. I was first introduced to this picture in PT school during our evidence-based practice classes, and it really kind of stuck around to me. um, so this slide has the three pillars of evidence-based practice. First, you have the research-based clinical evidence. That's your CPGs, that's your research, that's all the things that we've learned throughout PT school that gives us the evidence to do what we do in clinic. And then we have the clinical expertise on this side. This is the individual that goes through all the training and through all the work to actually come up with clinical diagnosis skills and intervention skills and things like that. And then you have patient preferences and values down here. That is the patient and their specific unique situation, right? What they believe in and how they view things from a cultural standpoint, from a societal standpoint, from a social economic standpoint, right? And these three pillars then connect to actually make evidence-based practice. You can't have one or the other to operate separately and give you the evidence-based practice that you want to do. And these three pillars then they live in this triangle of context, meaning the context in which you are operating all these under, right? Whether that's in an outpatient orthopedic setting or in a home health setting, or even just in the unique context of our society being in the US and our healthcare system, right? And then the other contextual factors that a patient might face, like again, like their social economic background or in the context of their culture. On this slide, when I was doing my research for this lecture, I went on to PubMed to actually look on the research on this topic, and you can see that this is a pretty heavily researched topic, having 27,000 results popped up when actually looking it up, and most of the research is in respect to medicine in general and not just physical therapy. But you can see one of the first things that popped up was shared decision making within the context of physical therapy management. So I think really what this slide brings is that shows that shared decision making is evidence-based in itself, and there is literature and research to support its use within healthcare. I put this slide in to actually be more thought-provoking and kind of help set the stage for this lecture. So how would you handle these situations? On the first situation here on the left, we have Cindy, who is a 71-year-old female with chronic knee OA and is deciding between continuing physical therapy, going with an injection, or having a surgical consult. The patient shares her concerns about recovery time, work demands, and long-term goals. How would you handle this situation? What would you do? Here on the right, you have Bob, who is a 28-year-old male that has acute low back pain and is considering whether or not to continue pursuing physical therapy, or conservative care, or going and getting some kind of diagnostic testing. The clinician explains what the evidence suggests, and the patient shares his concerns about fear of missing of something serious versus wanting to do unnecessary interventions. How would you handle this situation? And this kind of sets the stage for shared decision making. Both of these have situations that are very real and some things that you might encounter on a day-to-day basis. And each clinician will probably have a different answer to how they would handle this. So getting into the meat and potatoes here, what is shared decision making? Shared decision making is the collaborative process between two experts, the two experts being the clinician and the patient. It involves making health-related decisions together after discussing the available options, weighing the benefits and harms of each, and integrating the best available research evidence with the patient's values, preferences, and personal circumstance. Again, going back to that first picture of evidence-based medicine, you have those three pillars that actually make up what we consider quality care, right? Here on the left, you have the clinician's expertise, you have the evidence, you have the clinical knowledge, and then you have here the patient's expertise, what they live through, their values, their preferences, and their circumstances. And shared decision making is that bridge to connect those two pieces together, right? Again, we can't have those three pillars of evidence-based medicines work in silo. So why do we care about shared decision making? Well, first, it's an ethical imperative. Patients have the fundamental right to be informed and involved in their decisions about their own health, right? Um, Beyond ethics, the evidence shows real benefits. Shared decision making improves communication between patients and clinicians. It increases patients' understanding of their own conditions and the treatment options. It also reduces the anxiety and uncertainty when it comes to making difficult health decisions. It helps manage these expectations, right? We often overestimate benefits and underestimate harms when it comes to healthcare decisions. And so this opens up that discussions to then really dive into what are these benefits and harms. Studies show it enhances patient satisfaction with their care, and research even suggests that it could lead to better functional outcomes. When patients truly engage in their care decisions, they are more likely to follow through with treatment plans that aligns with their values, right? When we provide physical therapy interventions, we need to take into account the person that sits in front of us and what they believe will help them, as well as give our own inputs and what we believe will help them, and then try to marry those two together. In doing so, it reduces low value care when we can align our evidence with their values. Um, they're again more likely to adhere to a treatment program and be consistent with it. So here on this slide, kind of gives us an idea about whether or not PTs are actually practicing shared decision making, right? Well, much of shared decision-making research comes to medicine. The principles applied directly to physical therapy. Physical therapy is ideal for shared decision-making because so many of our decisions are preference sensitive, meaning that they rely on the patient's subjective reporting on their preferences, right? Do you want to work on some more manual therapy today, or do you want to exercise? What is the intensity of the treatment? What's your RPE? How are you feeling, right? Research shows that physical therapists value shared decision making, but we aren't actually doing shared decision making. There's some observational studies that reveal significant gaps. For example, you can see on the bottom here, studies show that therapists don't often present multiple options, don't consistently discuss benefits and harm, and don't always elicit patient preferences. And that's a real problem, right? Yet patients report that they want to be involved in these decisions. You can see here on this side is an observational study and of, again, it's a very small study group, but this is an outcome measure that actually is validated for measuring the extent in which shared decision making is occurring, and 100 being the highest possible score that you can obtain on this outcome. PTs on average are scoring about 5.2 in this study in Belgium. And again, this is another study in outpatient PTs back in England, but again, we're still scoring pretty low when it comes to these validated outcome measures on assessing shared decision making within PT clinical practice. Here in this slide, we're talking about when to actually apply shared decision making. Shared decision making is most valuable when there are more than one reasonable paths forward. Again, we call this preference-sensitive decisions. These decisions can have similar effectiveness but different harm profiles. For example, should a patient with NeoA try physical therapy, medications, injections, or surgery? Each option has its own benefits, risk, and burdens, and then the right choice depends on what matters most to the individual patient. Another time that is appropriate is long-term health conditions or managing chronic conditions where patients face ongoing decisions about their care, and then the volatility of things change week to week. It's generally also appropriate when there's insufficient evidence, right? If you have things that may be better than others, but we kind of don't know the evidence on it, laying it all out and laying the information in an unbiased manner could help patients make their own choices and decisions on whether or not to pursue one option or the other. Generally, it's not appropriate when there is one clear answer, right? If someone comes into the emergency room with an acute appendicitis, an appendectomy is generally what they will need to go under to be able to actually get a good outcome, right? You generally don't want to ask them whether or not they want to do an appendectomy or a gallbladder removal, right? So that's in a nutshell what shared decision making is. That's the definition of what shared decision making can be in a healthcare context. I think that most of us receive some kind of training in this and have some sense of idea. I think that it is a nice thing to kind of revisit and residency level training to go over this concept again, because I think it's very important in what we do from a physical therapy standpoint day to day, and also in healthcare in general. And so now we're going to get into how do we implement shared decision making. So here's a broad figure about the timeline or how things go within shared decision making, or some key elements here. This is a pretty lengthy slide, but we're going to go into detail about each section. Really, I wanted to highlight the point of this. In this figure, it's kind of like going in this linear progression, but generally, when you're dealing with humans, this is never the case, right? Each step and each individual and each interaction might not be this clean of a linear progression through this, but basically there is kind of steps that we get to that kind of help us navigate shared decision making as a skill. So these key elements can be simplified into this acronym that was developed by the Agency of Healthcare Research and Quality, known as the SHARE approach framework. This framework is broken down into 5 key processes. First, we seek patients' participation by inviting them into the decision-making process. Second, we help them explore and compare treatment options, including the benefits and harms of each. Third, we assess what matters most to them and their values and preferences. Fourth, we reach a decision together, ensuring that the patient is ready and has the information needed to make a full decision. Then finally, you evaluate the decision over time, checking in to see what's working for them. And so, again, we're going to go into these steps a little bit more in detail, but I think this is a nice framework to help you get started on the key areas to think about when it comes to shared decision making. So here is the first step. It's seek your patient's participation. Again, you want to invite them into the conversations. Many patients don't realize that there's decisions to be made, or they assume we'll just tell them what to do. We need to explicitly state that a decision is needed and that their input is essential. Language matters here, right? How you present these topics or present your ideas matters. And so how you ask them to be involved will matter. So some examples that you could say or phrases you can word is that there isn't one right answer here. Your preference matters. Or I want to go over all the options so we can find the best path that works for you. Or before I make a recommendations, I want to understand what is important to you. By asking these questions, we can get a better idea of their values. The simple invitation sets the stage for collaboration. It signals that we care about their perspective. It's about shifting, here's what you should do, to let's figure out what makes the most sense. The next step is to help your patients understand and explore treatment options. Once they're engaged, we can help them explore options. This means presenting all reasonable alternatives, including, when appropriate, the option to watchfully wait and do nothing for now. For each option, we explain both the potential harms and potential benefits. We use jargon-free language, and we help them navigate with patient-centered language. This is where patient aids can be incredibly helpful. These tools will be presented on a little bit later on. The key here is providing balanced information. We're not trying to steer patients towards one direction that we prefer. We're simply just giving them the information that they need to make an informed choice. This can feel uncomfortable at first, especially if we have strong opinions. But remember, we share the evidence, not the preference. Next, we assess their values and preference. I think this step is crucial and often overlooked. After presenting the options, we need to understand what matters most to a particular patient. We do this by asking open-ended questions like, what are you hoping for, or what worries you the most? These questions help us understand not just the medical aspects of the decisions, but the contextual factors, right? The goals, their fears, their values, their practical realities. One patient might prioritize pain relief above all else, while another might be more concerned about avoiding surgery. Someone might value being able to continue working, while another prioritizes spending quality time with their grandchild. We also need to listen to these practical barriers. They can be a financial barrier, they could be a transportation barrier, they can be a social barrier. Right? This information is essential for arriving at a decision that truly fits the patient's life. Again, we need to be more specific and tailored to the person sitting in front of us. After exploring options, and understanding what matters to the patients, we work towards a decision. Again, don't rush this step. It could take time. We can simply ask them if they need more time, more information, or want to consult a family member or a trusted advisor. Some patients are ready to decide during the visit. Others need to think it over. When patients ask for our recommendations, they often do, and we can absolutely provide them with one. But we need to frame it in a patient-centered ways. based on your symptoms and what you have told me that are important to you, I recommend X, Y, and Z. This shows we've listened and are making recommendations tailored to them and not just their condition. The goal is to reach a decision that the patient feels confident about, and one that aligns with both the evidence and their personal circumstance. Again, you can use these example languages here. Are you ready to decide, or would you like more time? Are there people that you would like to talk to? Additional questions you have. Based on what you've told me, I would recommend, right? Patient-centered language. Shared decision making doesn't often end in that one visit in this conversation. These decisions need to be evaluated over time. There needs to be follow-ups to check in. Is this treatment helpful? Are there unexpected challenges or side effects? Has anything changed for this patient's life that affects their ability to follow the plan? These plans and treatment options can be living things. They can grow, they can change, and they can mold and adapt over time. Healthcare isn't static, and neither are our patient lives. By building in this evaluation step, we demonstrate that we are partners in their care for a long term, not just for that one visit. We might say, let's review how this is working in 3 months, and if you're not seeing improvement, we can consider other options. Right? Again, the language matters in all of these steps. How do we present these ideas and ask for their input and get them to open up about their values, their preferences, and what will work best for them? Patients are really good about telling you what they need. We just have to listen and take the time to then consider those options within our own opinions and our own clinical knowledge and evidence. So here's some links to some additional resources provided by the Agency of Healthcare Research and Quality. These are video modules about the same kind of topics that we're talking about today, just in another format and a little bit more broader in spectrum of medicine, not just physical therapy. But I think these are very helpful to kind of hear some of these concepts again and get another perspective on all of this. And this slide is a broad overview of strategies on how to support shared decision making. We have big buckets here, but basically the first thing is understanding health literacy. There's some health literacy universal precautions when it comes to healthcare. We know that statistically speaking, there is a large majority of patients that have low health literacy. And so using patient-friendly language can be important on giving information. Then you have a teach back, right? Once you give information, we want to assess on whether or not a patient truly understands their options and understands the evidence that entails with those options. And so just by respectfully asking the patients to explain in their own words what they understood could be another way to actually confirm that they have truly understood the information provided to them. I use this all the time. I generally like to assess patients' knowledges when it comes to PT, just because there could be a lot in a single session, and sometimes PTs are really good about rambling and kind of talking more than listening. This next one is motivational interviewing. Throughout residency, we have lectures about motivational interviewing specifically, but basically it's a communication style that helps patients explore their own ambivalence and their behavior change to mobilize their intrinsic values and goals. It's a way to kind of get somebody to kind of see the values in the evidence and then persuade them in a way that is in good faith and in their best interest. Then you have patient decision aids, which we will kind of discuss, but basically these are tools, whether it's videos, worksheets, or just applications that you can actually give to patients And we'll kind of discuss this a little bit more, but these are unbiased, and there's also standards for patient decision aids. Here on the left, we have patient-reported outcome measures. We like to keep track of things over time, and again, this is a nice way to kind of get some objective data on whether or not patients do feel that shared decision making is happening and working for them. And we can objectively track that over time. So making patient-centered recommendations. It's a common misconception that shared decision making means that we can't make our own recommendations. This simply isn't true. Patients often want our guidance. They're coming to us for our expertise. The difference is how you make those recommendations. Instead of leading our recommendations based on solely on clinical factors, we first, again, needs to understand what is the most important to the patient. Then finding a recommendation that tailors towards those preferences. In this slide, you can kind of see that there's two approaches in the language that you can make. The first one being an example being that based on my test and your symptoms, I recommend X. Again, that is kind of a biased opinion rather than actually taking into account what matters most to the patient. The second example is a more patient-centered approach, being I'm happy to make recommendations, but first I want to understand what is important. Then, based on these tests and your symptoms, as well as what you've told me, I'd recommend blank. This is a patient-centered recommendation making and is entirely compatible with shared decision making. In fact, they're often exactly what patients need, our expert guidance framed in the context of their unique situation and values. So again, another strategy to employ shared decision making in part of helping patients navigate options are these patient decision aids. Patient decision aids are evidence-based tools specifically designed to help people participate in decisions about their healthcare. Quality decision aids have several key components. They provide information about health condition itself, describe all reasonable options, including watchful waiting when appropriate, present the benefits and harms of each options with probabilities when available, include exercises to help patients clarify their values and think about what matters most to them, and provide structured questions patients can use when discussing options with clinicians. It's important to be clear that decision aids are not just educational materials. Education alone doesn't constitute a decision aid. They're not persuasion tools designed to steer patients towards one option. They're not substitutes for talking with your clinician. They enhance the conversation, but not replacement. And they're not appropriate for all decisions, only for those where preferences matter and multiple reasonable options exist. A quality decision aid is balanced, evidence-based, and explicitly designed to support decision-making process. Again, these are standardized and they have quality criteria that they have to meet to be considered a decision aid. A booklet pamphlet isn't just a decision aid. Those are just information and just a pamphlet. But these decision aids can be really in-depth and in details. And again, they can incite patients' values and kind of get them thinking about what really matters most to them. But then they also do provide the non-biased, evidence-based information that then helps guide them in their education towards one decision over any other. Here are a couple links to decision aid libraries. The first one from Cochrane is pretty small, but has some applicable things like um, decision aids about osteoarthritis and some other rheumatoid diseases. Um, Colorado has its own specific patient-centered decision aids library where you can kind of click through and find different diagnoses and different decision aids for those diagnoses. And then the last one is a larger decision aid library made by the Ottawa Hospital. And again, they have hundreds of different decision aids for different medical diagnoses. So here's another topic that I think is worth discussing when it comes to shared decision making. Knowing the barriers of implementation can be very important and also can limit healthcare providers in employing some of these strategies. And they fall in line with three different categories. Some on the interpersonal level, where patient and clinicians can have barriers, different interactions could have barriers, and then in a broader scale, organizational and system level barriers could be in place. Right. At the interpersonal level, the actual interaction between patient and clinician, several barriers are presented. Traditional power dynamics in healthcare, um, positions between clinician as authorities and patients as passive recipients. This is changing, but decades of conditioning affect both parties. Patients and clinicians often have different expectations about their roles. The patients might expect to be told what to do, while the clinician assumes the patient wants options. Language and medical terminology create barriers. Even when we think we're using plain language, we often don't. There could be cultural differences profoundly affecting decision-making norms. Trust affects openness. Previous negative healthcare experiences can make patients reluctant to engage. Different communication styles, direct versus indirect, verbal versus nonverbal, can lead to misunderstandings. Specific clinical scenarios create barriers. In an acute crisis situation, can feel different than managing a chronic disease. Mental health considerations should not be ignored, including acute distress or even cognitive impairments. These interpersonal complexities are real and require thoughtful navigation. Right. On these individual levels, there's barriers that we can think of and affect different outcomes and affect different decisions, right? And as providers that see patients more regularly and for longer periods of time, we're kind of set up in these positions to be able to navigate these things and be more in tune and in tune with realizing and providing some source of help when it comes to these barriers. Now we get to the more challenging part of this, which is on the organizational or system level. Organizational barriers are often the most challenging because individual clinicians can't simply overcome them through personal effort. Time and resource constraints are paramount. Productivity metrics that reward quantity over quality preserve incentives. A clinician who spends extra time on shared decision making might be penalized for seeing fewer patients. Workflow and system issues create friction. If there's no systematic process for when and how to do shared decision making, it happens inconsistently. Poor care coordination, lack of continuity means decisions get fragmented across multiple clinicians. If an organizational culture prioritizes efficiencies over engagement, shared decision making feels counterculture. If leadership doesn't prioritize or support shared decision making, it remains a nice idea without teeth. If there's no accountability, no measurement, no quality metrics, shared decision making won't be prioritized. And that's, again, a harder thing to change, but I think um, when we get to the organizational and system level, it depends very greatly on the geographic location of things. It can vary even in the same city, state, county between different clinics and different healthcare systems, right? And so I think there is some work to be done here, and I don't have the answers into how that could be done, but I think starting to recognize these things and acknowledging them is the first step. And then even just acknowledging it on the individual level, I think is where change can happen. So at the individual level, how do we actually implement a shared decision making? Well, my advice is to start small. Um, Identify one common decision in your practice. Maybe it's options for lower back pain, or deciding whether to refer for imaging, or discussing surgery versus conservative care. Focus on implementing shared decision making for that one decision first. Practice the share approach in steps. Use and create a decision aid if possible. Once you're uncomfortable, then you can expand to other decisions. Starting small is the way to go here. We don't need to employ every single step of shared decision making all at once with every single patient, right? Um, the value of it comes over time and with practice, and starting at a place to where you're comfortable with is what you should do in the beginning. Implementation also requires support. If it isn't just about the individual clinician behavior, it requires team training, access to quality decision aids, protected time for these conversations, and organizational culture shifts that values patient engagement over efficiency metrics. I think that again, that is a little bit harder to do depending on where you end up working and what healthcare system your clinic operates under. But again, that could change with the individual efforts. And then lastly, practice the skills. Try patients centered recommendations. Try use teach back skills, document your shared decision making conversations, and reflect regularly. What's working, what's challenging, and then seek feedback. Change takes time, but every step towards a more collaborative decision making benefits your patients. Again, this is kind of going back to this organizational and cultural shift that needs to take place. It's more than just one person, two people, three people doing these things. It's about really organizations changing. While individual clinicians can start practicing today, widespread sustainable implementation requires organizational support. Healthcare institutions need to commit to shared decision making at a leadership level, incorporating it into mission statements, policies, and standard of care. Training programs should be available for all staff, not just clinicians. Decision aids should be integrated into EMR systems and easily accessible. Quality metrics should include measures of shared decision making, not just clinical outcomes and efficiencies. Organizations need to create culture that values patients' engagement, meaning allocating adequate time for patient encounters, recognizing and rewarding clinicians who practice shared decision making well, and support interprofessional collaboration. While we're not there yet, in many places, and organizational leaders can take concrete steps to support this approach. Change happens when we align individual commitment with institutional support. Again, a little harder to do, but I think just being aware and acknowledging these challenges is the first step. Um, and finding a solution that works for your institution and organization should be tailored and specific. Lastly, change can feel daunting, and thinking about systematic change on an individual level is not always practical. However, the foundation of change is the interactions between you and the patient in front of you. Every patient conversation is an opportunity to practice one or more elements of shared decision making. Maybe today you will focus on better eliciting preferences. Tomorrow, you work on explaining options more clearly. The next day, you practice patient-centered recommendations. My advice is to seek feedback from your colleagues and your patients, then reflect on what's working, what's challenging, and then be kind to yourself and your colleagues as you learn. It's something that is difficult and takes time to actually practice. Think about your own practice and what situations where you could start patients shared decision making with your next patient. Um, it could be something more regularly. Lastly, again, it's not about only doing the decisions that your patients come up with, right? If your patients came up to you and you did only what your patients wanted to do every day, then it's not going to be a good outcome either. It's about how do we blend those three areas, those three pillars of evidence-based medicine to get the desired outcomes, right? And it's a bridging those pillars together that really gives us the best outcomes. And that bridge includes two parties. That includes the clinician, the clinical experience, the evidence that they hold, and then as well as the patient, right? Their values, their unique situations and circumstances that really makes this feasible. Here are some podcasts where I actually kind of got this idea. I was listening on the way to clinic about this topic, and it kind of got piqued my interest, and I'd just like to share these links for anyone that does want to listen. Thank you for taking the time to listen to my lecture, and hope you have a wonderful day.